So I think in our discussion from the cardiology side, I think we've used the words many times how coronary calcium is part of the AHA-ACC guidelines and how I basically just wanted to show what are the consensus guidelines around, so one slide just to highlight what are the consensus guidelines around the use of coronary calcium. So what's indicated, you see in the red box, that it's indicated in intermediate risk patients, so those who have between a 5 and 20% risk of a heart attack or stroke over the next 10 years. So that's that pooled cohort equation or ASCVD risk score. And then if you have a 0 score, you can consider deferring statin therapy unless you have other very high-risk features, active cigarette smoking, strong family history, very high LDLs. And then as you have progressively higher coronary calcium scores, you can see the intensity of therapy is increased from moderate intensity to high intensity, and then with lower LDL targets. So it's really a precision prevention tool for us. And as you can see, it's from a 2022 American College of Cardiology expert consensus decision pathway. We have the pleasure of having Dr. Fusti here shortly to give his talk, and was president of the ACC at the time. And I think the one other thing we had talked about was, if you think about more along the cancer analogy, what are the ages that typically you have the disease, you have positive coronary artery calcium? The MESA study, the multi-ethnic subclinical atherosclerosis study, which we've seen a lot of data from, your chance becomes 1 in 4 of having a positive coronary calcium scan if you're a woman between 54 and 59 years of age, and that depends on race. And then in men, it's between 44 and 49 years of age. So I think most people don't recognize that, it starts early. And if we pick a threshold, which some could say that's a pretty high threshold, waiting until you had 1 in 4, you might want to know when you're 1 in 10 of having the underlying disease. So that's why I think we're very excited to collaborate here on how do we get more early detection for heart disease and lung disease. So to kick things off, it would be great to get some perspectives. We saw it a lot around the advances in the lung nodule and on the cardiovascular assessment. How do you think, when we think about integrating any of these tools or technologies, to try to be more intentional about looking for both together? Maybe Rick, any thoughts on that? Or
yeah, so that's been a hot topic for a long time. We've been a little bit focused in the last year or so on combination of lung nodule screening as well as emphysema. But to be honest, the requirements for detection of lung nodules are pretty close to what you need for measuring calcifications and other things. You need high resolution. You're pretty resilient to noise. The contrast is very high. And so it wouldn't be too much of a stretch. The challenge, though, as I mentioned in the past, is that when we create guidelines, we have to consider the sort of what's in the field right now, right? And the good news is that we've been collecting image quality data on lung screening scanners for the last 10 years. So we do have a chance of figuring out what would be a best fit to not, let's say the current scanners, but let's say the more emerging ones, the ones that are moving, the ones that are closer, let's say the ones that are being replaced and moving and our newer models. So I think there's hope for actually putting something together relatively quickly that'll do that.
And how much can AI do that for us as opposed to changing parameters of the scanner and other things?
I think we have great expectations for AI, and quite righteously so, because we're dealing with loads of data. And if there is one thing that computers are great at, is handling the data. I also think that, just to echo what Rick mentioned, AI is only as good as the data that is used to train it, but the data's got to be accurate. And I think that this is what we have dedicated. The part of this session is really to the part about the data, but then also looking a little bit further. I think from the technology standpoint, yes, there is plenty of things that can be done to simplify this, but I think technology is there to combine cardiac and thoracic and pulmonary screening and imaging. There has been a lot said, I think the other day, about value-based care. So when one part of the equation is value, but everything comes at a cost. So I think what we're discussing here is how can we further elevate this value piece so that the cost, whatever that is, whether that's a economic or dose or anything, stops playing such a significant role. And that's where I think our expectations towards AI and implementation of combining both is going to work great.
Any other thoughts from the panel?
My one comment is, for us, it's not even only about the AI algorithms. We have to be completely integrated into the radiologist workflow, the existing workflow. If we slow down a radiologist by 1 second, they will reject our software completely. They are underwater. In my career, I've never seen it this bad in terms of how loaded the radiologists are. Even if you look at the scans have 10 times more images than they did before. So everything has to be integrated really, really well for a radiologist to even say, I'm going to even use this.
Maybe one comment from my side. So it's very important that we as software companies know what to implement and what the decision pathways are then. I know that we should not say incidental findings anymore, but what are we doing if we find a high CAC score in lung cancer screening, and what are we supposed to do then, and how shall we display and manage?
I have a follow-up question. As we hear how busy the radiologists are, and we hear now how AI is integrated in the scanner and at every stage beyond the scanner, how soon before we will get a complete FDA-approved first read from the scanner so that radiologists no longer have to look through every of hundreds of axial slices in every chest scan? And can you give some ideas as to when you might expect that to happen?
That's a great question. I hate to say it in front of a radiologist, that's for sure. I'd say maybe between 15 to 20 years. It's a long time coming. It's got to be, the other thing I said about workflow, the other thing that radiologists really need is there's a head bleed algorithm from an Israeli company called ADOC. We implemented it 5 years ago in one practice I was in, and it worked amazingly well. That's when the company was like 15 people and 15 engineers. They grew crazy. They 400 US employees now. I implemented in another practice, and the sensitivity and specificity went down, so that if you looked at the posterior fossa, if there's a little motion, it would call it a bleed. If you looked at a arachnoid, if you look at the choroid plexus, it would call it a bleed. The radiologists rejected it, hands it down, because they were like, this doesn't work for me. It's not only about slowing you down, you have to be very, very accurate too. So and the problem is when you combine findings, when you want to look at, multiple findings at once, like a chest x-ray, we can look in 15 seconds and rule out 200-300 things. But if you want to have an AI algorithms work together, then it makes terrible mistakes right now. So I think it's a long ways coming. But I think a lot of people here, their guess is as good as mine.
I would absolutely agree. And also, AI can only find what it is looking for. And nodule detection detects nodules. So by definition, a cancer that's larger than 3 centimeter will not be found by these algorithms, and you just overlook it. You don't look at the images, you miss this very. And that's the current state.
So it turns out that we have an I-ELCAP AIRS project, which is a rule-out system. And we're in discussions with the FDA on submitting components of that system to FDA. And within a year or two, you'll be seeing a rule-out system being announced here with the AIRS project. So for lung nodules, not for not for everything. Was that your question, or was it for everything?
Probably more for everything.
For everything.
Or
There
so
are-
that you don't, so that all the main things that you do not have to go at image by image, detailed review of every slice.
Well, there are some technologies that'll get us there a lot faster than decades. So I would say stay tuned. I think we're on our way.
Stay tuned. That's a good one.
Yeah, I thought we could take some questions too.
Yeah.
You have the. There.
Hi, today we saw 3 CT vendors showing, this is really spectacular technology. The scanners just keep getting better, and we saw, a bunch of AI vendors. It's becoming apparent, though, that AI works differently with different protocols and with different scanners. And how are we going to monitor that? You heard the choroid plexus, example, and I think this is the next horizon that we're all kind of waking up to, that software doesn't behave the same. I mean, even in your chest x-rays, I wonder how your Cure AI does with Carestream versus Siemens versus G. I suspect it doesn't work the same, even as something as simple as a chest x-ray. And with CT, with all the parameters you can do with CT, I suspect the nodule detection, and especially, detection of nodules is the easiest thing, frankly. It's really measuring those nodules. That's where lung screening is all about. It's measuring, and I suspect there's big differences. So the idea of how we're going to understand how to use these systems under what circumstance, I think that's the next major frontier in terms of how we use this AI. And I'd be curious if there's agreement to that. And I think, Rick, you showed with your experiments that clearly there's abilities to optimize. And that's going to set thresholds, I think, for what you can do.
I just want you all to think, if you went to any manufacturer of software or hardware and said, get me a 30 to 50% improvement in bias and precision on small lung nodules, how would you do it? And how much would it cost? And how long would it take? We essentially are sitting with completely unoptimized systems, and we're starting to actually uncover what it takes to optimize them so that they work together. And it's fertile ground.
Maybe just to add to this real quick, I also think that besides the ability to optimize, I think there is a necessity to set up standards. We are often dealing with AI algorithms that are trained on data that's been collected years ago. There's nothing wrong about it. It's just that we don't skin this way anymore. And I think that perhaps putting some thresholds on this is what the minimum requirements are, then communicating them amongst the vendors that build equipment and develop AI algorithms, I think is an absolute must do as soon as possible. Because we're only going to see results of this exercise and initiative years from now. So the longer we wait, the longer this is going to come.
I think the FDA will eventually get to the point of saying, you know what, this scanner or this protocol, you can't measure change in nodules less than such and such a size. I mean, that's really where this, I think, has to head. Something like
I
that.
think that's right.
That's what we did in Kiba. And
There was a lot of people who got upset about that, but anyway. I think Jim wants.
I think that
There's a lot of speculation about a lot of pieces of this. And so the interchange we just had between Tony and Rick was very important because Tony's asking for a solution, a global solution, and there's not going to be a global solution. You've described AI tools for every piece of this along the way. Ilya, your comments, I think, are very well taken. Your colleague from Siemens, implied that preceded in our preceding presentation, saying it was an open architecture that they're building to because they're going to be ready to merge with other tools and other environments to do the job. I think the pre-competitive aspect of this is so important. Everybody wants a product to go forward and stuff like that. It's important. It has to happen. But I think when we use a portable computer, there's 250 patents wrapped up in that device that handshake all the time that allow us to get all these things done. And it's going to be the same thing in this environment for all kinds of obvious reasons for anybody who sat through the last 3 days. And so having standards of thresholds of performance, transparency in terms of parameters and stuff like that, the reference object that Rick has been describing is so fundamentally important. And that means everybody has to talk together to a degree, trust to a degree, because it's not a solution. It's going to be hundreds of solutions that are going to have to be very, very rapidly interactive.
piggyback to what Jim mentioned. So 20 years ago, when Dr. Fuster was leading a new wave, and it was imaging in cardiology, the today was not clear. We had MRI, we had a bunch of other technologies trying to bring image to patient care. The last 3 days, it was absolutely black and white clear that for screening, for early detection, for mass population adoption, we have the tool. That's a low dose chest CT. That covers 70 to 80% of cause of mortality, as you saw going, because we cover about 2/3 of liver in that, and we showed the predictive value of osteotosis in there. So that's, Jim, a major progress has been made in the last 20 years. Now, we need to turn this to that computer that you said, that is on everybody's lap, became the laptop. We make this widely available, inexpensive, easily integrated into the patient care, not create another island like these full body MRI companies are doing and this, or longevity people. Integrate into the mainstream medicine, but bring the technology that has gone through the last 20, 30 years of fighting with each other, trying to show what works for patient care. So I think we have made tremendous amount of progress, and you will hear from Dr. Fuster's overview of how we're going towards bringing this to the ultimate goal. Again, ultimate goal is not the prettiest image, not the fancy AI that reports the entire CVD and everything. The goal is reduce mortality, preventable death. What today happens in 50 to 75, 80-year-old for now, at least, a lot of them are preventable. None of those MIs are necessary. None of those strokes are necessary. They do not need to be there. Cancer, I don't have a clear answer to mutation yet, but early detection, the way Claudia showed, is equal to cure. I mean, you have seen the data last 2 days. So we bring this to mass adoption. We don't wait for people to come to a hospital. We go where people are, get it done fast. I think we will transition this to the 21st, everybody was dreaming about for prevention and integration of the technology. Back to you, Mark.
I was just going to say, I think that's a great way to close out this session. Thank all of our panelists and moderators, and we can pass the baton.